Good evening. Welcome to the Black Doctoral Network weekly web series Conversation Starters. I'm your moderator, Fese Longe, and I am thrilled that you all could join us again for another season of wonderful topics that are relevant to the African American community. Tonight's topic is entitled Addressing Healthcare Disparities in the Black Community. Joining me this evening, we have two expert scholars that will share their knowledge and insight on how the healthcare disparities affect the community. Our first panelist joining us is Dr. Kia Davis, who is a social epidemiologist and assistant professor in the Division of Public Health. And also, she's on the leadership team of the Siteman Cancer Center's Community Outreach and Engagement. With over 16 years of being a health equity scholar, she enjoys conducting action-oriented policy research on understanding how structural racism impacts chronic diseases and solutions to address this impact. I welcome you, Dr. Davis.
Thank you so much. I'm happy to be here.
Thank you. Our second panelist joining us is Dr. James Bush, who is a decorated military veteran, speaker, and author. He's also a senior solutions trainer, consultant for Thrive, adjunct professor of health sciences at Anthem College, and also the founder and executive director of the Lizzie Porter Foundation. Dr. Bush enjoys providing healthcare awareness and education to African Americans, healthcare informatics, as well as hospital revenue cycle solutions. I welcome you, Dr. Bush.
Thank you. Happy to be here.
Thank you. So I want to go ahead and jump right in. I think this is a fabulous topic, and I know our viewers are biting at the bit, so we can go ahead and get started. So the first question that I have for you all is, what are some prevalent healthcare conditions in the Black community? Dr. Davis.
Gosh, there's so many. So I've been doing health disparities research for a while, and with the focus on chronic disease. So there's a higher prevalence of heart disease, hypertension. Additionally, Black people are more likely to have worse outcomes and are more likely to die from most cancers across other racial and ethnic groups. For example, Black men are 50% more likely to die from prostate cancer. Black women are 40% more likely to die from breast cancer. Black children are more likely to have asthma. Almost any condition you can think about is prevalent in the Black community.
Thank you, Dr. Davis. And Dr. Bush?
I would agree. I think the easier question was, what don't we have in the Black community? I think everything is prevalent amongst our community, and it's all stemming obviously from one commonality, racism. I would only add to Dr. Davis's very long list. Mental health issues have also been a prevalent healthcare condition amongst our community.
Thank you, Dr. Bush. So this goes into the next question that I have for you all is, what are the current healthcare disparities in the Black community? Dr. Bush.
All of them. I just said all of them. So there's a multitude of current prevalent issues that are facing us now. While some are chronic illnesses and ailments that can be now managed through modern medicines, I would say that the just access to preventative measures is one of the more prevalent things that I feel as a person who kind of specializes in patient access and access to healthcare. Many of our communities, I think all you have to do is pull up a map and look at all of course, the surrounding hospitals. What's the proximity for an individual who's maybe being reared in a impoverished neighborhood? From those individuals, of those families in those impoverished neighborhoods, do they actually have insurance to go to that local facility? Many of, of course, our African American fellow families out there only go to see their provider. And I say their provider loosely. Typically, it's just the ER that they're going to go see, and they don't actually have a primary care physician or provider to help with those preventative measures, which is horrible because we don't treat our cars that way. When you hear something knocking in your car, you get it checked immediately. But when it comes to healthcare in our community, it's the wheels are falling off when we go in to go see something versus just getting that air in the tire or those monthly maintenances. So I would say one of the more prevalent things or current things would, of course, be just right now access to quality healthcare amongst the African American community.
No, thank you, Dr. Bush, for that information and your insight. Dr. Davis, what are your thoughts?
I would agree. There are disparities before you even get to the hospital door, right? So in addition to access, there's a lot of research now around food deserts, right? Do you have access to high quality, healthy foods? Do you have a safe place where you can exercise? Like all of these things kind of create a situation where Black people are more likely to be obese and more likely to have most of the chronic diseases that I just mentioned. And if you're able to manage it well, to still have poor quality of life, more comorbidities, so things you just, do not allow you to live your healthiest life.
Thank you. Thank you both for breaking that down and just giving the audience a bit more insight into the healthcare disparities that are out there. So looking more at some of the external factors, the next question I have is, how do cultural perceptions impact healthcare utilization? Dr. Davis.
Sure. So I think there are a host of, we use racial disparities in a way that for some physicians essentially have preconceived notions about what treatment regimens Black people might follow, might not present, and they might not present all the options. They might have preconceived notions about their pain levels and what type of pain they can tolerate, and so taking complaints about pain seriously. So I think there are several preconceived notions that physicians might have that allow them to not really treat the whole person, the whole Black person. And there are also cultural experiences that Black people have experienced, whether it's themselves or someone in their family or a friend of a friend that they've heard about who went to a certain hospital and had a poor experience, and now no one in the family or no one in the community wants to go to that hospital. So I think it definitely hinders us on both sides.
Thank you, Dr. Davis. And Dr. Bush, what are your thoughts?
I think Dr. Davis hit the nail squarely on the head. It's twofold. Back in 2016, there were a list of newly minted medical professionals who actually thought that African American skin was tougher than white people's skin. And this was just back in 2016. Well, if you add 10 years to that, because it takes about 10 years to fully become a practicing medical doctor, they're still out there. Those individuals are still out there providing treatment. This preconception or this ingrained bias has been just weaved into our society ever since slavery. African Americans or Black people back then, their first introduction was to a doctor on the stages of slavery. They were checked out by a physician before they were sold off to the next family. In the 1800s, I think we can think is it James Sims, Dr. James Sims, who is now known as the father of gynecology. He did horrendous studies on African American women with no type of anesthetic or medicine to assist in pain management for those women. And the list just kind of goes on and on, well before the Tuskegee syphilis experiment. So there's all these perceptions that were used to kind of support the notion of slavery and how we were inferior as a people. And that has just been woven into, of course, modern medicine. Pearson's even had to do a redaction of one of their recent nursing books where it stated in there that Black people experience pain at a higher level or will complain more about pain at a higher rate than white patients. And that was in a recent Pearson's medical textbook for students to learn. So, and then of course, on the flip side of that coin, then you have, of course, the experiences lived by African American people we learn about medicine the same way that we learn how to cook sweet potato pie, or how we learn how to cook collard greens and stuff like that. That's passed down from one generation to the next. Many of your big moms or your me moms, their experience was going through the back door of that local hospital, or going to an all Black hospital altogether. And when they were allowed, of course, to go into the white facilities to be treated by white physicians, again, it was very poor treatment. I did hear a story of a young lady, or at this time a senior, who went in, of course, to just for a simple root canal. You can't go in for a root canal back then. They would just pull your tooth. So that would build a fear, of course, for these people. And then they, of course, will spread that fear, of course, to their children, and so on and so forth. Just generational things. So again, these perceptions are on both sides.
No, thank you, Dr. Bush and Dr. Davis. I think I just love how you all just, Dr. Davis providing, the current biases and narratives that a lot of the physicians have, and Dr. Bush really going into like the historical aspect of where this actually comes from. So I really appreciate you all really conceptualizing so people can understand this is nothing that just occurred today. It's something that goes back a long ways. So thank you. So the next question that I have is, how can culturally inclusive interventions improve the delivery of healthcare services to African Americans? Dr. Davis.
Well, I think having culturally sensitive, culturally aware programs can only help. So I think these programs kind of facilitate communication between physicians and the community to break down some of those barriers, to break down some of those misconceptions that we were just talking about. And also just to like, modern healthcare it's set up for the convenience of doctors, not really for communities. And so having culturally relevant programs kind of help break some of that down. So for example, if you're doing shift work, can you take off to have, your primary care appointment one day, then you have to go back the next day for another appointment, right? Because insurance won't pay for a set of schedule, all of your tests on the same day. So, thinking about how do you switch your hours? How do you make this a place where people are interested in coming, and also aware and open to what you have to say about health and prevention, and just taking care of yourself.
Thank you, Dr. Davis. And Dr. Bush.
Everything Dr. Davis is supported by tons of studies. Studies show that, of course, a person's adherence to their healthcare plan is based off, of course, their trust within the actual provider themselves. And you are more likely, of course, to adhere to that plan. And not only do I trust Dr. Davis, but if Dr. Davis also looks like me and understands my actual community and where I'm coming from. In many instances, there's a lack of representation amongst African Americans in the healthcare industry. It was actually what my study was conducted on itself. That representation could help with that, with those inclusive interventions that the question asked about. And it's more than just the lower level, because you do see African Americans represented in the at the ground level when it comes to healthcare facilities. However, from someone on the vendor side, like I am, who goes in and I go into the C-suites, I see, of course, all the executive leaders. As you climb higher and higher up that elevator towards the top of that facility, there's very few melanated individuals making those calls and those decisions about the healthcare of that community, even when that facility is located in a predominantly African American or person of color type of community. So definitely, of course, these not only incorporating programs, but incorporating people inside, of course, those buildings and those walls to help drive those programs, so that it's not just a checkbox for that facility, that we have an inclusion program to handle our African American population, that the community can come in and see people that look like them, that talk like them. Sometimes the words that you're saying just don't resonate, of course, with the community. But baby, I don't know what sodium is. I don't know what that is. What is that, honey? Okay. Well, then, no, Mom. What I'm saying is leave Popeyes alone. Is what I'm saying. Sometimes you
Mhm.
need that provider to, for lack of a better term, code switch, so that that individual can understand the severity of whatever illness or ailment that's raging within their system, and they can make the appropriate decision about their own lives and their health care.
No, thank you, Dr. Bush and Dr. Davis. And I just want to reach out to our audience members. I hope you all are enjoying this conversation. And if you are, please feel free to leave any comments or any type of questions. And our panelists here have not a problem addressing them and really digging deep into any of the concerns that you all may have. And we do have a comment here. It said from Miss Janet Coles, I tuned in a little late, but did you guys discuss implicit bias and how it contributes to health inequities? So, here a bit of a question in here. I don't know if it's Dr. Davis. Would you like to answer?
Sure. I didn't use the word implicit bias specifically, but that's what I meant. We talked about how physicians have these preconceived notions of how Black people may or may not engage in treatment for whether it's cancer or any chronic disease, also in terms of pain tolerance. And that is absolutely implicit bias. Sometimes it's explicit, but sometimes it is implicit.
Thank
Absolutely.
you. Go
And I just brought
ahead.
up the 2016 study on those graduates, those medical graduates who, of course, had implicit bias about the thickness and the pain level and tolerance of African Americans. So there's definitely implicit bias across the board.
Thank you all for answering that. So, the next question that I have for you all is, how has the COVID-19 pandemic impacted African Americans' perception of healthcare? Dr. Bush.
Well, I had to sit back on that one. Ah, okay. All right. This is where, for those who are listening in, I informed Dr. Davis that I'm a bit of work at times, and I like to forget sometimes about all these degrees. How has COVID-19, the pandemic, of course, impacted the African American? Well, our perception of healthcare has always been one of a negative light. And I think COVID-19 has definitely shined an even brighter light on our community and the disparities that we face on a national and actually worldwide stage. Um, from the African American perspective, I think for some, it just fermented their distrust of the healthcare system. I think that's obviously partly because of the leadership that we currently had in office during the initial portion of the pandemic. If you are constantly being fed lies, then you don't know who to trust or what to trust, especially from a community that had little to no trust in the federal government and the agencies that surround it from the start. And so what that has led to is a series of people then believing in things that aren't real. For a long time, of course, I believed that Santa Claus squeezed down my project's non-chimney that I didn't have, and of course dropped off gifts every single year. And it wasn't until I got real information that my grandmother and my mom were buying those gifts and putting and wrapping them up and putting them, of course, underneath the tree, then I didn't believe. But before that, I just believed these outlandish notions. And I think the same thing goes, of course, for our community at times. Now, I mean, I'm sure Dr. Davis has heard about the microchip thing, and they're tracking you, and this does this. Like, it's just a plethora of craziness that kind of has infused itself into our community, and it's actually it's disheartening, especially for some of us who have been in healthcare all of our lives. We've studied these of course these journals, these scientific journals. We of course worked in this environment, and then to have to go so so far back to really explain something as simple as how helpful a vaccination can be or wearing a mask can be.
Mhm. Thank you, Dr. Bush. Dr. Davis.
I absolutely agree. I think COVID simply kind of reinforced what the community already knew. which is that Black communities, underserved communities, are often the very last thought. And it contributed to a lot of the myths and misinformation in the Black community, but also contributed to just a lack of support. So there was a lot of support for first responders, for nurses, for doctors, being on the front lines of the COVID pandemic and getting exposed. There was no support for our blue collar grocery store workers, the transportation folks, the people in sanitation in hospitals who help keep the infrastructure going, and are more likely to be Black because that's how oppression works. And then when those folks lined up to get vaccines in their community, they weren't there. So I think just in many scenarios, it reinforced that we're all we got in some ways. Like there were lots of community organizing to get vaccines in their communities, just to get testing in their communities because people still have to work to put food on the table. So I think it reinforced and empowered a lot of folks to go out and claim what they needed for their health.
Yeah, thank you, Dr. Davis. And I put this question out there because I'm sure a lot of our audience members really want to know. I mean, they probably were living these issues on a daily basis. So thank you all for providing your insight on that question. So the next question that I have is, how significant are community organizations in addressing healthcare disparities? Dr. Davis.
Very. Healthcare, and I work for a cancer center. We can't do it on our own. They call some populations hard to reach, and they're not. We're just doing a bad job of outreach, right? And I think that's something that the community organizations can help with. They can help you identify folks, and they can also call healthcare centers, out to point out what did they need to change and perhaps reorganize to make it, again, a more welcoming place for community members to come. But I definitely think community organizations have been instrumental in my work in terms of thinking about, like, where are the blind spots in healthcare, right? Like, healthcare has a tendency to just do things the way they've always done and hope that people will catch up. But if you design healthcare for the least of these, then everyone ends up benefiting. But we have not done that for some reason. So I think those community organizations are those folks that hold us accountable, and that say, what about this group? How can we provide support and resources, and how can we get people in? So in terms of community advisory boards, health disparities committees for community outreach and engagement, I think that community input in community organizations has just been instrumental in help bridging that divide and really supporting bi-directional communication from community to healthcare systems.
Thank you, Dr. Davis. And Dr. Bush.
I completely agree. As one of those community organizations myself, there needs to be someone who acts as a conduit between the two, the actual community itself, and of course those healthcare providers that are out there. In many instances, they just don't know where to receive certain services, or they think those services have a particular fee associated with them. And of course, we have those professionals on the other side who are attempting to have outreach, but they can't, for whatever reason, go past specific barriers to get to those in the community. And this is where those programs or those organizations come into play. And I'll tell you another great resource. It's actually churches. I know during this time, lots of Black churches with prominent pastors and leaders, knowledgeable pastors and leaders, have stepped forward and convinced their own congregations about the importance of preventative measures that they can take, not only, of course, with COVID-19, but other healthcare disparities. And they do some of joining of course, the facilities in the community to get those things out there, because some of these organizations are kind of tiny, so they need lots of them to reach those cracks and crevices, so that we can all move together forward.
Thank you, Dr. Bush. And this goes into the next question that I have, because I know we've talked a bit about a lot of the different strategies, but more concisely, what various strategies can the healthcare system actually implement to improve the healthcare participation in the Black community? Dr. Bush.
Well, we probably should not just target just the individual diagnosis or disease. In order to improve this process, Black people or African Americans need holistic of medicine or a holistic approach where we're not just looking at this ailment. Yes, it's broken, but why is it broken? What happened that caused us to get to this particular point? And in order to do that, you're going to have to tackle things that are technically outside of healthcare in order to improve healthcare. One key factor, obviously, is racism. That is a key stressor for many individuals, and some would argue, of course, that it's not the 1960s anymore, or it's not the 1800s anymore. What are you talking about? But of course, we already know that there's covert racism built, of course, into our wonderful society that we have here. Any scholar who studies a critical race theory knows that it's actually ingrained in the thread of this fabric that we call America. I've heard one analogy of a weathering pattern that many of us face. So yes, I might be in great condition, but as racism slowly drips onto that concrete over time, while it looks fine now, that concrete will weather and crack away, causing, of course, all of those that laundry list of things that we spoke about at the very beginning of this hour. So one thing that we can do, of course, as our system is change the way that we conduct healthcare in the United States. We have what's called an employee-based healthcare system. Well, prior obviously to the Affordable Health Care Act, but we have an employee-based healthcare system, meaning you have to have a job first. You have to have a job in order to get healthcare insurance to go see your provider. Well, what happens when those individuals are underemployed or unemployed, which 9 times out of 10, of course, are African Americans in our communities? That means they can't get, of course, those preventative measures in place to check on the high blood pressure or to check on their diabetes and their cholesterol levels, causing them to go down that avenue of disparities. We have to, of course, address our housing and economic crisis that we have. As mentioned by Dr. Davis, we have what are called food deserts. So if I have, and even I live in a wonderful metropolitan area of Atlanta, Georgia, but there are still areas within this very chocolate city that I live in that it will take it's miles for you to get fresh fruit and vegetables. However, it's only a block to get churches, and it's only a block to get a bottle of Hennessy, family favorite. But all joking aside, economics and infrastructure and obviously racism, those things are kind of outside of the circle when it comes to healthcare. But all those things have to be addressed in order to improve our healthcare situation.
Thank you, Dr. Bush. And Dr. Davis, what are your thoughts?
I absolutely agree. It's not an individual level solution. But to add, I'll say that hospitals need to think more creatively about how they're using their community benefits to be able to address some of the upstream factors that Dr. Bush mentioned in terms of racism and housing and food insecurity. And I will also think about like the actual healthcare process, right? How can that be changed? So there's research going on at UNC, and they did this study where they implemented an anti-racism intervention in a cancer center, and that required anti-racism training for all of the heads of hospitals, so all of the high-level folks, all of the service level folks, but also it incorporated community health nurse navigators and health equity trainings, and health equity updates implemented in grand rounds. And what they saw over time was that treatment disparities were reduced for early stage breast cancer and early stage lung cancer. The disparity was reduced, but it also increased treatment completion for everyone, comparing Black and white patients. So there's a way that we can do this and make this equitable and give everyone access. But yes, in addition to, we cannot forget the upstream factors, because if we're just treating these individual hurts, some other health condition is just going to blossom up later, right? Like we'll put a Band-Aid on one and then the bleeding will go somewhere else. So
thank you, Dr. Davis and Dr. Bush, for really highlighting the various factors and strategies and it definitely does take the healthcare system to change their strategies and their outlook and how the actual system implements. So I thank you both for that. Well, this concludes the questions that I have on this topic, but I have one more question that I would love to ask you both. How has your affiliation with the Black Doctoral Network helped to enhance you personally and or professionally? Dr. Davis.
So I'm a new member. So as I said, I'm very new. So I would say it's definitely enhanced my professional network because I get to meet all of you and have this conversation. So this is one of my first activities as a new member, and I'm very excited to be here and participate.
Thank you, Dr. Davis, and a welcome. And I hope you enjoy all the wonderful things that BDN has to offer. Dr. Bush.
There's a wonderful saying that if you could see it, you can be it. Just being around or being in the presence of such greatness and excellence it's just constantly motivating. I know for a lot of scholars or academics, when you're newly graduated, you're newly minted, that doctor, you may have maybe have matriculated from a school where you were the only individual that looked like you. It's just phenomenal to be in a room or being in the presence, not the room, clearly we're virtual now, but being in the presence of so many individuals of like mind and to learn about everyone else's studies and what their interests are, and to even have conversations just like this. I guarantee you right now, I'm going to go on to Dr. Davis's LinkedIn and increase my network by one phenomenal individual.
Thank you.
Thank you, Dr. Bush, and thank you for sharing your presence with us again and your continued membership. Well, before we go, I wanted you all to take the opportunity to share some of your contact information with our viewers. So, in case they had any additional questions, they'll be able to get in contact with you. So, Dr. Bush, how can they contact you?
Oh, awesome. I am Dr. J. Bush, DRJAYBUSH, on all forms of social media. My Twitter is Dr. J. Bush1 because somebody else took it. I don't know who the other Dr. Bush is. Or you can just go to my website. It has all the links and everything on it, drjbush.com.
Thank you. And Dr. Davis.
Sure. Feel free to email me at daviskl@wustl.edu. And I'm also on LinkedIn as Kia Davis. I have social media, but it'll be a while before you get a response. So just
they're in your DMs, doctor.
Just
Don't tell them they're in your DMs.
No, I don't look at them. That's the thing. It'll be 3 months, and I'm like, wait, what did I do? But yeah, LinkedIn is fine. So.
Thank you, Dr. Davis. Well, I have to say, it's been a pleasure having you all discuss this wonderful topic. And I just want to say thank you for taking the time out of your schedule this evening to join me as we discuss addressing healthcare disparities in the Black community. If you have enjoyed Conversation Starters and would like to keep up to date with the latest BDN developments, please be sure to check us out on blackphdnetwork.org and become a member, or follow us on Facebook at Black Doctoral Network. Please be sure to share this live session with your friends, families, colleagues, and professional networks. I am your moderator, Fese Elonge. Thank you, wonderful panelists, and to all a good night and good evening.
Thank you.